My name is Kavar, one of the good afternoon, everyone. My name is Kavar. I'm a PGY6 here at University of Texas Southwestern Medical Center, Dallas, Texas. And it is my absolute pleasure here to welcome all of you for the start of this year ONTPD academic year grand rounds. I have an absolute pleasure to introduce Dr. Veronica Tanner, who is a pediatric nephrologist, and she is affiliated with Children's Nebraska in Omaha in Nebraska Medicine. She received her medical degree from Drexel University College of Medicine, so right here in Texas, and then completed her pediatric residency and nephrology fellowship training at Cincinnati Children's. She is an assistant professor of pediatrics at the University of Nebraska Medical Center and also a medical director of the Pediatric Kidney Transplant Program and as a site PI for the Improving Renal Outcomes Collaborative that advance the health outcomes for kidney transplant recipient. She is the medical director of education for Division of Nephrology at University of Nebraska Medical Center and is passionate about teaching all aspects of kidney diseases and care. I'm going to give floor to Dr. Taylor.
Wonderful. Thank you very much for having me here today. It is my pleasure to discuss neonatal nephrology with a focus on electrolytes and kidney function. I have no disclosures. My objectives today are to review kidney and urinary tract development, discuss how kidney maturation impacts the glomerular filtration rate, fluid status, and electrolytes in neonates, discuss potential complications of premature renal tubules, and propose how to evaluate specific electrolyte abnormalities in neonates with a focus on sodium-potassium derangements. So let's start with how the kidneys develop. Well, the kidneys develop in three different stages. We have the pronephros, the mesonephros, and the metanephros. The pronephros is the most primitive structure of the embryonic kidney. It arises from the intermediate mesoderm. It's really non-functional and it regresses by about week 5 of gestation. We then go into the mesonephros, which is the transient embryonic kidney, and it primarily serves to influence gonadal function, and it degenerates by about 10 weeks gestation. We then have the metanephros, which is the true kidney state. So let's take a closer look at the metanephros as this becomes the permanent kidney. The metanephros forms when the ureteric bud pokes into the metanephric blastema. The ureteric bud then becomes the collecting system, and this includes things like your renal pelvis, your calyces, and your ureter. The metanephric mesoderm then becomes the nephron. Nephrogenesis occurs through 4 stages and starts around 9 weeks of gestation. Stage 1 of nephrogenesis is renal vesicle formation. And this is when the ureteric bud will express proteins, which induces the mesenchymal release of reciprocal hormones. Stage 2 is body formation, and this is when the renal vesicle grows and transitions from a comma-shaped vesicle to an S-shaped vesicle. Stage 4 is stage 3 is vascularization, when we have endothelial precursors that migrate in. And then stage 4 is the functional form, and this is when the collecting ducts connect to the nephrons. The metanephros starts producing urine around 10 weeks gestation, and it becomes the primary source of amniotic fluid of about 16 to 18 weeks gestation. Just so we all remember, the primary role of amniotic fluid is for pulmonary development because the placenta will do the majority of the homeostatic function. Fetal kidneys will start developing in the pelvis, and then they'll migrate upward around weeks 6 to 9 of gestation. The fetal kidney receives only a very small fraction, about 5% of cardiac output. This increases to about 9% for the newborn kidney, and then adult kidneys receive about 25% of the cardiac output. This is important to discuss as this change in cardiac output is going to impact how newborn kidneys manage their fluid and electrolytes. And for fetal and newborn kidneys, most of this blood flow is going to go to the inner cortex of the kidney, with very little blood flow going to the outer renal cortex. As fetal and newborn nephrons receive a very low cardiac output, they're really going to depend on maximal pressure to generate the filtrates. And they do this by balancing blood flow into the glomerulus from the afferent arteriole and how much blood is leaving through to the efferent arteriole. The renin-angiotensin-aldosterone system is highly active in fetal and newborn kidneys. The very high level of renin will cause a very high level of aldosterone, and this causes constriction of your afferent and your efferent arterioles. However, the kidneys are also exposed to very high levels of prostaglandins, and this dilates the afferent arteriole. As a net result, we have a dilated afferent and a constricted efferent arteriole, and this results in a maximum intraglomerular pressure. You can then see how ACE inhibitors, medications that can dilate your efferent arteriole, or NSAIDs, which counteract prostaglandins, can cause significant decrease in fetal or nephron kidney function. Kidney function is very low at birth, but your glomerular filtration rate will double in the first 2 weeks of life. And this occurs from an increase in renal blood flow to the outer cortex of the kidney, an increase in glomerular permeability, and also increase in your mean arterial pressure. Your glomerular filtration rate will continue to rise and typically reaches adult levels by about 1 to 2 years of life. However, preterm infants will have a much lower kidney function at birth as they have fewer number of available nephrons, and their GFR is much slower to rise. As we discussed, glomerular genesis begins around 9 weeks gestation. However, 60% of the nephrons are formed during the 3rd trimester, and the entire nephron complement of the human kidney is determined by about 36 weeks gestation. At term, each kidney holds approximately 900,000 nephrons, but there's wide variation, and birth weight really correlates with your number of glomeruli. Given these factors, both preterm birth and factors that restrict intrauterine growth can result in decreased nephron endowment. And this is even worse for preterm infants who also have low birth weight. Factors such as micronutrient deficiency, placental insufficiency, hypoxia, exposure to nephrotoxic drugs, or moms who have diabetes, chronic kidney disease, or smoking or alcohol can really impact developing kidneys. We know that these nephrons must last a lifetime as nephrons do not have the ability to regenerate. And for everyone, the number of functional nephrons gradually declines over time, and this leads to the age-dependent decline in kidney function that we see in older adults. Extrauterine nephrogenesis continues about only for a maximum of 40 days after birth. And these glomeruli that develop afterwards are really characterized by abnormal features. And even with these 40 days, preterm infants really never reach the full complement of nephrons as their full-term colleagues. Unlike nephrogenesis, though, tubulogenesis continues after birth, and tubular function significantly improves in the first month of life. And this is due to increased renal blood flow from reduced vascular resistance and an increase in cardiac output that results in tubular elongation. This tubular elongation then results in improved absorption of glucose, amino acids, phosphorus, increased secretion of other things like potassium and acids, and really helps with urine concentration. So you might be asking, how does this pertain to me? What could go wrong during development that's going to affect these neonates? Well, we know that infants who have absent or poorly functioning kidneys, this then will result in oligo or anhydramnios, and that can result in pulmonary hypoplasia for these infants. Kidneys that fail to migrate out of the pelvis will then result in patients having a kidney in their pelvis, or pelvic kidneys, or an ectopic kidney. These patients who have pelvic kidneys are at increased risk for traumatic kidney injury, higher risk for reflux and obstruction. We know that developing kidneys normally need to have high cell turnover to allow for remodeling, and things that disrupt this system, such as obstruction to the nephron, can trigger apoptosis, and this can lead to renal hypoplasia or aplasia, and this is why we see babies being born with a solitary kidney. We also know that low cardiac output is dedicated to these newborn kidneys. And again, most of the blood flow is going to that inner cortex. So if a patient undergoes obstetric complications such as eclampsia, placental previa, or postpartum hemorrhage, this can result in cortical necrosis or death of the outer layers of the kidney, and that can lead to acute kidney injury, decreased urine output, and hypertension. We also know that premature infants can have a lot of renal complications, and this can include things like renal hypoplasia, so small kidneys, hypertension, proteinuria, and chronic kidney disease. Brenner hypothesized how patients with prematurity and low birth weight can go on to develop chronic kidney disease. And what Brenner proposed is that patients who have a decreased nephron number, such as those who are born premature, can initially maintain a normal glomerular filtration rate as these individual nephrons hypertrophy to increase their total surface area. And this is called hyperfiltration. Over time, this adaptive process becomes harmful, though. The increased glomerular surface area leads to increased sodium retention and systemic hypertension. This hyperfiltration disrupts the renal autoregulatory mechanisms, and this generates intraglomerular hypertension and glomerular sclerosis. This hypertrophy of these glomeruli also results in ineffective lengthening of the podocyte foot processes and subsequent proteinuria and podocyte detachment. This glomerular sclerosis and loss of nephrons then results in chronic kidney disease. And this result then leads to additional decline in nephron number, which then leads to greater hypofiltration in the remaining nephrons, resulting in a very vicious cycle of chronic kidney disease. So how significant is this chronic kidney disease? Well, there are many studies on this, but just let's take a look at one. This was a study done by Crump et al., which was a large Swedish cohort study of 4 million individuals that looked at the relationship between prematurity and the risk of chronic kidney disease in childhood to mid-adulthood. And what they found was that preterm birth was associated with a twofold increase in chronic kidney disease for these individuals, again, during childhood to mid-adulthood, so not later on in life. And extremely premature infants were associated with a threefold increase in chronic kidney disease. And this association was highest during ages 0 to 9. And this risk is even higher for those not only born premature, but who also have a history of low birth weight. And this really shows us the importance of how important it is to address factors during the neonatal period to decrease the risk for future chronic kidney disease, such as limiting nephrotoxic exposure and preventing acute kidney injury for these premature infants. But also how important it is for long-term monitoring of these kidney function for these neonates. So let's now move away from kidney function and let's take a look at how neonates manage their fluid and electrolytes. Before we talk about neonates, though, let's just review some normal physiology. The renin-angiotensin-aldosterone system, as we know, is a hormone system that regulates blood pressure, fluid, and electrolyte balance, and also systemic vascular resistance. The liver secretes angiotensinogen, and this gets converted into angiotensin 1 by renin that's secreted by the kidney. This then gets converted into angiotensin 2. Angiotensin 2 then results in increased sympathetic activity and vasoconstriction. Angiotensin 2 stimulates the release of aldosterone. Aldosterone will then go to your renal collecting ducts to reabsorb sodium and water and excrete potassium. And angiotensin 2 also stimulates release of antidiuretic hormone from your pituitary gland, which then goes to your renal collecting duct to insert aquaporins to reabsorb water. Let's take a closer look at the nephron itself to see how it manages sodium and water balance. We know that about 65% of sodium filtrate is reabsorbed in the proximal tubule. And much of this is regulated by the sodium-potassium ATPase. This is going to become important because your sodium-potassium ATPase is not very active in newborns. So we'll come back to this in a little bit. About 25% of your sodium filtrate is going to be reabsorbed in your ascending loop of Henle, and about 10% of the sodium filtrate is reabsorbed in your distal tubule and your collecting duct. And here we can see where different diuretics act on the nephron to cause sodium wasting and diuresis. Water balance for the neonate is really dependent on the patient's kidney function, how much fluid they're intaking, and how much water they're losing. And we know that newborns are very susceptible to water derangements. And this is because of postnatal changes that occur in their body water components, their immature kidneys and their tubules, their increase in sensible water losses, and also their inability to access free water. We know that preterm infants are even more susceptible because they have a greater magnitude of postnatal diuresis. Their kidneys are even more immature and they have a much higher insensible fluid loss. The amount of total body water as a percentage of body weight and its distribution in various fluid components increases with decreasing gestation age. In the term neonate, the total body water is about 70% of the body weight, as compared to about 80-90% in infants who are born less than 27 weeks. And the biggest difference between these neonates is really due to their extracellular fluid volumes. Normally, between birth and about day of life 1, the infant is in the pre-diuretic phase, and this is really characterized by oliguria. Then starting around days 2 to 3, they'll undergo the diuretic and natriuretic phase. And this is due to an isotonic loss of your extracellular fluid compartment. And we know that the magnitude of this diuresis and natriuretic phase and duration of it increase with decreasing gestation age, such that your preterm infants are at much higher risk for fluid and sodium losses. And why does this occur? Well, we have lung fluid that's being absorbed, then it goes into your extracellular fluid compartment so that your kidneys can respond to it. But then the lungs also get increased blood flow that leads to increased blood in the left atrium. So then you have a secretion of your atrial natriuretic peptide, which then stimulates sodium secretion itself, but also inhibits aldosterone release. And all of this results in the diuresis and natriuresis that we see in newborns. Newborns also have a very low urine concentrating ability. And this is due to their short loops of Henle that really restrict their countercurrent multiplication system. They have decreased medullary concentration of sodium chloride and also urea. They have decreased sensitivity of the collecting duct to antidiuretic hormone. And they also have very high levels of prostanoids, which counteract this antidiuretic hormone. And newborn kidneys also have a much lower concentration of aquaporin channels to allow for that reabsorption of free water. This concentration ability, though, increases rapidly after birth, and really you reach the full capacity of concentration about 2 months of age. This is in everyone except for your preterm infants, where this is much slower to occur. And so again, your preterm infants are a much higher rate for volume depletion, and then they can risk for hypernatremia as a result. Besides urine, infants can lose water from other sources, and this includes the skin. We know that evaporation can result in a very large and sensible fluid loss for neonates. And this is even greater for your extremely low birth weight infants and extremely premature infants, as they have a very much larger surface area to volume ratio. We know that other factors can contribute too, including compromised sting integrity for your babies who have abdominal wall deficits, those who are under radiant warmers. We know that radiant warmers increase your evaporative water loss by about 50%. We can counteract this by using humidification and plastic wrap to minimize this loss. And newer incubators are being provided that can provide humidification, which can decrease free water loss. Other things such as heat-emitting phototherapy devices can increase transepidermal water loss. There are new phototherapy devices that are being used, including LED phototherapy, which really don't affect your transepidermal water loss. But for those who are on conventional phototherapy, this can increase your free water requirement by about 10%. We also know that infants can lose water through their lungs too, especially for premature infants. And we can decrease this by providing humidification. And this is also less for those who are mechanically ventilated. The ideal fluid then comes up with, what do we give these infants when they're born? Well, the ideal fluid in the first couple of days of life really allows for that appropriate contraction of the extracellular space and physiologic weight loss to help out the lungs, but not causing so much as your patient develops hypernatremia. And for term infants, we estimate this typically about 60 to 80 mLs per kilo per day. and higher at about 100 to 120 mLs per kilo per day for these preterm infants. But really, you must have to take a look at your infant and see what their weight is, how rapidly are they losing free water, what's their respiratory status, what's their serum sodium, or are they having other gastric losses that we need to account for? So it really should be an individualized approach. Taking a look at sodium management, sodium reabsorption is really limited in newborn kidneys due to their tubular immaturity. Newborn kidneys have a poor response to aldosterone. They have a decreased expression of sodium channels. And again, they have decreased expression and function of the sodium potassium ATPase that we talked about earlier, and have fewer number of these membrane transporters. This is even further limited in preterm infants. So if you take a look at the fractional excretion of sodium for term infants, it's about 2%. Whereas if you look at it in premature infants less than 30 weeks, it's up to about 6%. And so preterm infants, not only do they have more sodium in their urine, the high sodium in the urine lasts for even longer period of time. However, we know, though, that newborns need a positive sodium balance. And for most infants, they shift to a positive sodium balance by about 2 to 3 weeks of life. So around this time, their fractional excretion of sodium should be less than 1%. Again, slower for preterm infants. And this change in the sodium balance occurs because now the kidneys are getting more blood flow, they have increased oxygen availability, their proximal tubules start to lengthen, they have increased sodium transport activity, they respond better to aldosterone, and again, now they're getting more of this activity, that sodium potassium ATPase. But we know that there are a lot of benefits to sodium supplementation, especially for our preterm infants. We know that sodium supplementation can enhance somatic growth. It's associated with decreased BPD, and we think this is because the clearance of alveolar fluid is dependent on a sodium-stimulated transport of your ENaC channels and your sodium potassium ATPase. Infants who supplement sodium are at decreased risk for retinopathy at prematurity, and also neurodevelopmental outcomes. There is a study by Alderon et al. Back in 2002, and they looked at sodium supplementation for preterm infants less than 33 weeks, giving them about 4 to 5 milliequivalents per kilo per day between day of life 4 and 14. And these children at 10 to 13 years of life, so years down the line, had better memory, better learning, better language, and education performance compared to their preterm colleagues that did not get sodium supplementation. But how much sodium do we really need to give these patients, and how does this really impair their somatic growth? Well, we know that sodium is important for growth because inadequate sodium decreases absorption of your glucose in your gut through your SGLT1. We also know that suboptimal stimulation of enteroendocrine cells occurs when you don't have enough sodium and also results in low growth factors. And low sodium can result in lower cellular pH, and this inhibits proper cellular growth. So really, for these infants to grow, they need appropriate sodium intake. So when should we supplement sodium? Well, there is some evidence that although sodium has all these benefits, delaying sodium supplementation to allow for the natural diuresis in preterm infants may be beneficial. There was a trial involving preterm infants of about 25 to 30 weeks gestation, looking at giving sodium supplementation on day of life 2 versus delaying supplementation until these infants had a natural weight loss of about 6%. And what they found is that in those who we delayed sodium supplementation, they were significantly more likely to be on room air by day of life 7. And there was no difference in regain to birth weight and no differences in weight between these individuals between 36 weeks of birth and 6 months. We also know that failure to allow for this normal diuresis that's occurred can result in increased risk for patent ductus arteriosus, increase the risk for neck, and also increase the risk for BPD. But how much sodium supplementation do we give these infants? So if we look at a study by Salter et al. Back just a year ago, they looked at newborns ages 26 to 29 weeks gestation, And they gave them sodium supplementation after they were 2 weeks old, and when their serum sodium was less than 132, or their urine sodium started getting less than 40 millicoulombs per liter. And they gave them 4 millicoulombs per kilo of sodium, and they stopped this when these babies were over 38 weeks, or when their serum sodium started to get over 144. And what they saw is that these infants had, again, better somatic growth, better head circumference, increased body weight, decreased mechanical ventilation, but also there was no difference in the risk of hypernatremia, sepsis, or hypertension. But we have other studies that show, well, infants even less than this, like 23 weeks, might require even more sodium, up to 8 millicoulombs per kilo per day. And those who are on diuretics might even require even more, 12 millicoulombs per kilo per day. So really, you must individualize how much sodium you give these patients based on their individual needs. So how do we approach a patient then who has a sodium imbalance? Well, typically, hyponatremia is typically due to an excess of total body water. And hypernatremia is typically due to a deficiency of total body water, except in patients who are newborns and except in those who have kidney abnormalities. So really, when looking at a patient who has a sodium imbalance, we want to know, well, how much sodium and how much fluid intake is the patient getting? What has been their weight trend? On their physical exam, what is their fluid status? What has their blood pressure been? We might need to look at serum studies such as their chemistry, what are their serum osms, and also might need to look at some urine studies like what are their urine sodium, what's their urine osms, how well are they able to concentrate their urine. Typically, how I approach things for hyponatremia is looking at how old the infant is. Typically, in the early newborn period, between day of life 1 and 5, hyponatremia is typically due to either excess fluid intake, we're giving them too much free water, or these infants have SIADH. So water retention due to inappropriate ADH secretion, which can be from anything these infants can have, like pneumonia, meningitis, IVH, and typically how we treat this is with fluid restriction. For these patients then in the late newborn period, so after day of life 5, then I think they're more likely to have a negative sodium balance. And this can be because of kidney sodium losses in premature infants, those who are on diuretics, those who have had kidney injury, so in their post-acute kidney injury recovery period, or if they have congenital abnormalities of the kidney and urinary tract, so they're just losing sodium in their urine, infants who have GI losses, and then other causes like congenital adrenal hyperplasia. So for treatment of these infants, I'm thinking more that we need to replete their sodium deficit, but then also give them enough sodium to account for their ongoing sodium needs. And so this is the equation that we typically use to calculate their sodium deficit. And for these infants, if this has been a chronic and we want to bring them up, we want to correct their serum sodium slowly, so no more than 10 to 12 milliequivalents per liter per day. And of course, if the infant has severe hyponatremia and is seizing, then of course we want to give things like hypertonic saline. Late hyponatremia is actually really common in preterm infants. If you look at infants who were born less than 28 weeks, more than 90% are going to have late onset hyponatremia. And for infants who are born 29 to 32 weeks, it's about 18% of them. And risk factors for this are infants who are born, again, lower gestational age, if they have a lower birth weight, if they're only on parental nutrition for a short period of time, or if they're on diuretics. And why do these infants have hyponatremia? Well, again, they have short loops of Henle, they have reduced sodium transporters, they have this diminished response to ADH, and also aldosterone. We also know it can also be from decreased sodium intake because human milk fortifiers are typically very low in sodium. And also we know that milk from mothers of preterm infants is naturally higher in sodium than the sodium content of donor breast milk. So if I have an infant, though, that's really I'm not sure which way they're going, why do they actually have hyponatremia? This is the algorithm I'll typically go down to make sure I'm on the correct route and how to treat their hyponatremia. So first we want to check a plasma osm. If a patient has a normal plasma osm, then I know that they have isotonic hyponatremia, in which case I'm thinking, okay, they have pseudohyponatremia. This is probably something like hyperlipidemia or high levels of protein in the blood, so I'll check labs on them. If the patient has high serum osms, so they have hypertonic hyponatremia, then I'm looking for things like, are they hyperglycemic? Have they recently got administration of things like mannitol or radiocontrast? However, if they have hypotonic hyponatremia, so their serum osmols are low, then I'm going to go down the following pathway, which is based on their volume status. So if we take a look at patients who are hypovolemic, the next step would then be to check their urine sodium. If their urine sodium is low, and so is their total fluid status, then we know that their kidneys are not appropriately conserving, so they're having renal loss of their sodium. And this can be from things like diuretics, mineralocorticoid deficiency, if they have an underlying nephropathy, or again, your premature kidneys that just can't hold on to sodium. If the urine sodium is low, then I know that their kidneys are doing the correct job and they're retaining sodium appropriately. So then looking for extra renal sodium loss, such as from vomiting or diarrhea. Regardless of the cause, though, for both of these, really the treatment is giving them sodium back and giving them fluid back. If the patients, though, their fluid status is hypervolemic, then I'm still going to do the same thing by taking a look at their urine sodium. If they're hypervolemic and their urine sodium is high, then I know that I'm concerned more for kidney failure. If their urine sodium is low,
Dr. Lane, updates.
If their kidneys are able to maintain or reabsorb urine sodium, then I'm looking for things like heart failure. Does the infant have cirrhosis or nephrotic syndrome? And for these conditions, really, it's fluid restriction. If the patient has euvolemia, then I'm more looking at their urine osms. If urine osms are high, then I'm thinking things like SAADH and endocrinopathy, such as thyroid disease, adrenal insufficiency. And for these patients, it's fluid restriction, but also treating the underlying condition. If their urine osms are low, then I'm thinking they have low solute intake. They're getting more free water than their sodium content. So for them, I'm going to decrease their free water intake, but sometimes they may not need some extra sodium too. With hypernatremia is typically due to excessive water loss. And this can be from inadequate fluid replacement of insensible losses, or such as from their skin or respiratory system, or from sensible losses such as their urine losses and their GI losses. Sometimes this is from our inappropriate estimation of how much their sensible losses are. Sometimes it can be from things like inadequate breastfeeding. It can also be from things like diabetes insipidus, particularly for babies who have HIE or CNS malformations. And for these babies, you're going to look at comparing their serum osms to their urine osms. Infants who have congenital abnormalities of the kidney and urinary tract, or those who are in the recovery phase of acute kidney injury, can also have a decreased urine concentration ability. So they might be losing more free water in their urine than sodium, so they may be a higher risk for hypernatremia. For these infants, we want to give free water administration. And here's the calculation that we will use to calculate their free water deficits. And like treatment of hyponatremia, again, you want to correct this slowly, no more than 10 to 12 millicolons per liter per day, because if you do it too fast, this can result in cerebral edema and seizures. Hypernatremia without significant weight loss, though, or without a fluid deficit, should really prompt us, though, to search for inadvertent high sodium administration. And neonatal hyponatremia can be caused by excessive sodium delivered through parenteral fluids. Think of all the sodium flushes that our patients get that we might not be accounting for, sodium that has to go along with medications we provide them, and blood products like albumin that we give patients has a ton of sodium in it. And this can occur very easily in preterm infants. If their hypernatremia is caused by excessive sodium intake, obviously we want to reduce their sodium intake and give free water if necessary. Sometimes if the infants are edematous from this, they might need diuretics in addition. Moving on from sodium to potassium, we know that neonates have a much higher serum sodium level due to their decreased renal excretion of potassium. And this is because of their decreased glomerular filtration rate, the kidneys' reduced sensitivity to aldosterone, the shift that occurs after birth from intercellular to extracellular potassium, the decreased activity of the kidneys' ROM-K and MAXI-K channels. And again, we always come back to that decreased expression and activity of that sodium-potassium ATPase. Interestingly, there have been studies looking at neonatal steroids, which upregulate your sodium-potassium ATPase, and they might be used to help manage hyperkalemia after birth. What about hypokalemia? Well, we know that potassium loss can occur through things like diuretic use, renal tubular deficits, such as after an acute kidney injury or after obstruction during this recovery period, or other interesting things like Barter's-Gilliman's Fanconi syndrome. Also, loss of potassium through GI for patients who have ileostomies or NG tubes, patients who have excess middlecorticoid activity, or also in patients who have low magnesium. Hypokalemia can also occur through this intracellular movement of potassium. So for patients who have alkalosis, who are on insulin, beta agonists, refeeding syndrome, or infants who have thyrotoxicosis. For patients who have hypokalemia, they can initially be asymptomatic. However, they can also develop other symptoms such as weakness, paralysis, ileus. It can lead to urinary retention, hypotension, decreased reflexes, and then long-term it can lead to polyuria, causing a decreased renal concentration ability. Eventually, you can get conduction deficits such as ST segment depression, low voltage T waves, and U waves. If we're trying to figure out, is this patient having potassium loss through their kidneys? Are the kidneys the what's going on? We can do something called calculating a transtubular potassium gradient. And here's the equation that we use for that. The most important thing I would like you to know about this is the serum and the urine studies need to get attained at the same time, and it's most helpful to obtain before you decide to replete the patient's potassium, so when they're actually hypokalemic. And as we know, the treatment for hypokalemia is just giving them more potassium back. What about hyperkalemia? Well, hyperkalemia can occur through decreased potassium clearance, such as in patients who have kidney failure, congenital adrenal hypoplasia, hypoaldosteronism, or medications that interfere with your renin-angiotensin-aldosterone system. So ACE inhibitors, ARBs that decrease your aldosterone, medications that can decrease your renin, such as your NSAIDs or beta blockers, or medication that interfere with aldosterone receptor functioning, such as calcineurin inhibitors. Medications such as spironolactone that are competitive antagonists for aldosterone receptors can also contribute. And also medications that decrease your ENaC channel functioning, such as amiloride, can also lead to decreased potassium clearance. Hyperkalemia can also result from extracellular shifts or tissue destruction, such as from hemolysis, rhabdo, patients who are acidotic or on beta blockers, have hypoinsulinemia or have DKA. And of course, if we give too much potassium through like patients who get a lot of packed red blood cell transfusions or have too much TPN, that can reduce your potassium. And then everyone's favorite pseudohyperkalemia are patients who get heel sticks and it's just falsely high. For patients who have hyperkalemia, they can go all the way from just being asymptomatic to a medical emergency. And how we diagnose hyperkalemia is the first thing you want to do is check a venipuncture potassium, make sure that it's accurate, and also get an EKG. And you're looking for peak T waves, flattened P waves, increased PR interval, and widening of that QRS complex. We also want to, of course, check their kidney function, see if they're in kidney failure. If you're concerned, then later on, you can check other things like calculating your transtubular potassium gradient or checking things like renin and aldosterone. And of course, making sure your patient's not truly acidotic. So how do we treat hyperkalemia? Well, the most important thing is cardiac membrane stabilization. Your cardiac myocyte depolarization really depends on your extracellular potassium concentration. And hyperkalemia can raise your resting potential closer to that threshold potential. And what calcium does is it counters this by raising that threshold potential to mitigate cardiac excitability. We can use things like potassium shifters. So things like insulin and albuterol can stimulate that sodium potassium ATPase to drive potassium inside. Sodium bicarb we can give because that stimulates your hydrogen potassium exchanger. We can use potassium excretors such as diuretics. Again, only helpful if your patient is already making urine, it's not anuric. Or we can use potassium binders like sodium pyrestyrene, so Kxalate. However, these should be used very cautiously in those who have GI motility issues, as it can increase your risk for intestinal necrosis. These also contain a very high sodium load, and so can increase your risk for your patient becoming fluid overloaded too. In older patients, we can use other things like sodium zirconium and patiromer. These are more approved for older children and adolescents. Sometimes we'll use these in younger children, but typically not neonates. And then, of course, dialysis is the treatment of choice for severe life-threatening hyperkalemia or in those who have kidney failure. I wanted to also take a moment to also discuss glucose. Glucose is completely absorbed in the proximal tubule of the kidney via secondary active transport mechanisms. It's driven by that sodium potassium ATPase that creates an electrical gradient that drives your SGLT co-transporter of sodium and glucose. In the glomerulus, the filter load increases in proportion to the plasma. In adults, reabsorption will match the filter load until your plasma glucose gets to be 200. So in adult patients, when their serum glucose gets above 200, that's when we're going to start seeing glucose in their urine. However, infants, particularly newborns that are premature or have very low birth weights, they have a much lower tubular glucose reabsorption. And so we can actually start seeing glucose in their urine when their serum glucose is only about 150 to 180. And this is because, again, they have shorter tubules and decreased number of that sodium potassium ATPase and decreased number of SGLT transporters. As your tubules grow, though, so do the number of transporters. So this does improve over time. But because preterm infants and those who are very low birth weight are at higher risk for glucosuria, this can result in increased osmotic diuresis. So they're at very high risk for dehydration if they get glucosuria. Looking at the renal buffering system, the kidneys regulate your acid and base homeostasis through bicarb reabsorption and also hydrogen ion secretion. In the glomerulus, bicarbonate ions are really freely filtered in the proximal tubule, and around 80% of normally reabsorbed through the action of your carbonic anhydrase and also your sodium bicarb co-transporter. This process is maintained by your potassium ATPase and your sodium potassium ATPase. In the alpha intercalated cell, hydrogen ions can be excreted, and the predominant mechanism is excreted as titratable ions, with the majority occurring as ammonium. In the distal tubules and the collecting ducts, hydrogen ions are actively secreted into the lumen via hydrogen ATPase and hydrogen potassium ATPases. As shown in the figure on the right of the alpha intercalated cell and the collecting duct, we can kind of see how the kidney maintains this renal buffering system. Infants have reduced bicarbonate reabsorption and urine acidifying capacity until about 2 months of age. And this is due to a decreased number of bicarbonate transporters. Again, this low activity of your sodium potassium ATPase and your hydrogen ATPase, reduce ammoniogenesis, and reduce activity of your carbonic anhydrase. Like many other things, this capacity is further reduced in premature infants. We know that around 2 weeks of life, you tend to become less acidotic because more bicarb is reabsorbed due to this volume contraction that occurs for these infants. So if a patient has a anion gap metabolic acidosis after 2 weeks, then we want to continue to think, is there something else going on, like a renal tubular acidosis? And how we do this is we look at their blood gas to first confirm that, yes, this is a metabolic acidosis. We want to look at electrolytes such as their sodium, their chloride, their bicarbonates, look at their pH, and also calculate their urine anion gap. And then we want to try to see which type of RTA do we think the patient has. We can look at proximal RTAs, also known as type 2 RTAs, which occurs from decreased reabsorption of bicarbonate in the proximal tubule. When we have a patient with this, we think of things like something is going on in the proximal tubule, such as cystinosis or glycogen storage diseases. These patients will also lose other things in the proximal tubule, so you'll see glucoseuria, proteinuria, other things going on. In the distal type of RTA, this is caused by impaired distal acidification, and for these patients, is usually caused by a genetic problem, or if you have a patient who's been exposed to like amphotericin B. Type 4 RTAs, this is when the kidneys have a decreased aldosterone effect, so patients who have adrenal insufficiency or sometimes kidney disease. And these patients, you're also going to see hyperkalemia, so in addition to treating their acidosis, you also want to correct their hyperkalemia at the same time. Looking at also how the kidneys look at metabolic alkalosis, how we approach patients with this is the first thing we want to do is take a look at their volume status. If they're volume depleted, what we want to do is take a look at their urine chloride. If a patient has a low urine chloride, that means the kidneys are retaining onto it. We're thinking of things like they're alkalotic because they're vomiting, or they have a lot of severe NG or OG suctioning, or they have a lot of gastroesophageal reflux disease. We also want to consider other things like, do they have congenital chloride diarrhea? Do they have pyloric stenosis or cystic fibrosis? If their urine chloride is high, then we want to think of other things like, are they on diuretics? Should we consider workup for something like barter or Gilliman? Or do they have something more simple like a potassium or magnesium deficiency? If they have metabolic alkalosis, though, and their volume expanded, then we think they have a high aldosterone effect. And so in this case, we want to measure their plasma renin activity level. And if the renin level is high, then we want to look for things like a renin-secreting tumor, or do they have renal artery stenosis? If their renin level is low, then we think of things like adenoma, AME, Chiari-Little syndrome, or Cushing syndrome. So this is really the approach of how I take to work up different electrolyte abnormalities, different acid-base status, and really fluid management for infants. Here's my references. And I'd be happy to take any questions.
Thank you so much, Dr. Taylor. For the folks online, please scan the QR code. I'm going to post the link here as well. The people who are using the laptops. And we would happy to take questions. I did not see a question in the chat box. So if you have a question, you can unmute yourself and ask the question directly.
See. All right, that was a great talk. Thank you, Veronica. I don't see any questions coming through. But thank you. This was a great beginning to our board review series that we're going to be doing this year. Hope everyone get prepared for their Neo boards.
Great. Thank you much for having me.
Oh, wait, somebody said something. I heard that treating hyponatremia in the first few days of life can be corrected rapidly with less concern for brain issues. Does that match with what you see as well?
That's most likely correct, because during gestation, mom's placenta controls most of that, and so we think that the hyponatremia is probably acute, and so because it's acute, you can probably rapidly correct it with less concern for changes in the fluid status in the brain. looks like the next question is, what are some special considerations or differences approach you would recommend for sodium in EPPs? Sorry, I'm not a neonatologist. What is EPP or extremely low birth weight? For those who are extremely low birth weight, we know that these babies have their renal tubules are not well formed, and it's going to take them much longer to conserve sodium. And so for these infants, they might be hyponatremic for quite some time. For other infants at about like 1 month of age, where I think, oh, something must else be going on with them, why are they still hyponatremic? For these babies who are extremely low birth weight or extremely premature, they might still be requiring sodium supplementation for quite some time, especially if they have a BPD or they're on diuretics for other things. They can require quite a lot of sodium for some time. Whereas other infants who are more closer to term, if they're still hyponatremic by like a 1 month of age, then I'm doing kind of more of a workup, looking at their urine sodium, checking other things going on to make sure nothing else is going on.
All right. Thank you so much, Veronica. Please join us again next month for Dr. Shivani Patel, who's going to be doing a cardiology lecture, and he is from Lurie Children's.
Thanks so much, everyone. Please don't forget to use the QR code.
All right. Thank you, Veronica, so much.
Thank you.
Thank you, Dr. Bye.